Healing Minds, Changing Attitudes is underwritten by the Arkansas Mental Health Research and Training Institute.
Hello and welcome to Healing Minds, Changing Attitudes. I'm your host, Pamela Smith. On this program, we're going to take a look at first episode Psychosis, also referred to as FEP. We will be discussing what it is and the type of care and treatment mental health professionals are providing all over Arkansas. Joining me to speak on this very important topic are Dr. Roland Irwin, a clinical psychologist and the clinical director at Mid-South Health Systems. Dr. Lisa Evans, clinical director at the Little Rock Community Mental Health Center and assistant professor at the University of Arkansas for Medical Sciences Department of Psychiatry. Tony Sisson, a licensed professional counselor and adult services division director at Community Counseling Services Incorporated. Frency Hempel, a licensed clinical social worker and first episode of Psychosis coordinator at the Department of Human Services Division of Behavioral Health. And finally, Dr. Nihit Kumar, a child and adolescent psychiatrist at the University of Arkansas for Medical Sciences and a board member of the Arkansas chapter of the National Alliance on Mental Illness. Thank you all very much for being here to discuss what we know is obviously a very important and timely discussion, and we're going to kick it off with you, Dr. Kumar. Let's talk about psychosis, the definition for it, and how you differentiate that from other mental health concerns.
Right, so psychosis is a symptom which is part of a bigger chronic mental health disorder called schizophrenia. Schizophrenia and any other mental health disorders are actually diagnosed by using the criteria in the DSM, which is the Diagnostic and Statistical Manual, and it includes symptoms such as delusions, hallucinations, paranoia, and there are some negative symptoms including, flattening of affect, poverty of thought, and such.
Mm-hmm. So how prevalent is it nationally, and then let's bring it back home, how prevalent is it in Arkansas?
Right, so the prevalence of schizophrenia nationally, internationally, and in Arkansas is 1%. That means about 1 in 100 person will have schizophrenia.
Okay, well, those are some very interesting statistics, and as you and I were discussing earlier, you talked about the difference between the burden of schizophrenia, and we'll get into a little bit more of that in just a moment. But I want to bring our next guest in on our conversation, Ms. Hempel, if you will. We talked about when you can detect the onset of schizophrenia, so let's talk about that for our audience and help them understand when it's diagnosed.
When it's diagnosed? Well, I guess as it relates to first episode, and the reason that we're here today, all gathered here today, is we're finding that that first episode often occurs in late adolescence or early adulthood. Mm-hmm. And so we want to be able to treat people when it first occurs. And so all over the state, our community mental health centers are geared up to provide that treatment, and we've got people here today that just kind of can talk more about that for you.
Well, it's great to have this esteemed panel of experts here. When you say adolescence, is that typically the time that we start seeing signs of schizophrenia? Because typically when we hear about it in the headlines, it's already reached a boiling point, if you will. So when would we see it presented? Is it adolescence the only time, or are there some key indicators that might lead to a diagnosis?
Well, you can begin to see those symptoms late adolescence, pretty much, early adulthood. I think typically for males it might be about 18, or women 24. Some signs that we want to key into, particularly for this population, this first episode when it first occurs. Those people may be living at home, so they may be living with parents, they may be going to school, they may be beginning to work, and it's usually that sudden change, that decrease kind of in what we say functioning. Maybe the adolescent or the young adult was going to school, but now they may be kind of in the room, not talking to anybody, and so those sudden change changes that we want to key into and get folks in for an evaluation or an assessment.
But it sounds to me, and any of you can chime in if you feel like it, but it sounds to me like some of the symptoms might mirror other things, as I was asking you initially about how you differentiate. So, I mean, what is the dividing line, if you will? Because it does sound like it could mirror some other illnesses.
Right, some of the early signs do mimic normal adolescent behavior sometimes. Even social withdrawal or even suspiciousness can look sort of normal. So I think it is a little hard to identify quickly. When true psychosis starts to develop, people do tend to have some odd and unusual behaviors. They certainly might even say some things that are unusual. They might have disorganized speech, where they would say some words in strings of sentences that don't really make sense or don't have kind of an objective to them. But you're right, depressed mood, irritability, the things that come early might look like other things like depression or even regular adolescent behavior. So it's important to educate the community and family members to help them identify it early. And what Fritzi was saying, that it happens at this really important critical age where people are finishing the degree or maybe even starting college, and creates this burden of disability when they're not able to finish that.
So talk, if you will, about how it compares to other mental health issues in terms of diagnosis and then in terms of treatment, Dr. Irwin.
Well, in terms of treatment with schizophrenia, the initial thing we want to do is get the person on medication, and that is the core, the base treatment.
Is that the only treatment?
No, that's absolutely not the only treatment, but that's where we want to begin. And we'll first identify, the person, and then get them in. We want to encourage them to take medicine because that is the most effective way of improving the primary symptoms, like Dr. Kumar was talking about, the hallucinations and the delusions, those most debilitating symptoms of schizophrenia. But the other things that we do and that we really want to make a focus on here tonight are there are other interventions that we can assist the person with that involve reaching out to them in the community and helping them, number one, in education. It's very important that the person experiencing this understand what's going on with them. Imagine yourself if you begin to hear voices talking to you and you can't understand where it's coming from, or if you begin to have beliefs about people persecuting you or trying to harm you in some way. You think that's real. But part of this is educating them on this is an illness, it's not really happening to you. And that's a long process of developing that relationship with the individual so that they trust you as the provider of treatment enough to listen to what you're saying. So education is very important. Teaching them what we call generally coping skills. How do you deal with it when you're hearing voices all day long? The medicines can help with that, but there are other things that we can teach them to do. Relaxation skills, problem-solving skills, things that they can learn to do that, although they don't directly affect the voices and make the voices go away, but you can learn to not have that bother you as much.
Well, I'm sorry, I didn't want to cut you off. Go ahead and you finish that thought, and then I wanted to ask you something.
So if you're understanding the voices to be something that you're going to deal with the rest of your life, and it's a very pessimistic view of it, and I'll never overcome this, then it's going to affect you worse emotionally than if you come to understand that, hey, I can learn to deal with this, and even though that's kind of playing in the background of my mind, I can go on with life. And so a lot of what we do is work with them on trying to get back on track with education, with work skills, the education about the illness, and teaching them to get better control of their life. We want them to recover from this to the extent that they can, and we're learning that really recovery is a real goal for people with schizophrenia.
Okay, hold that thought.
Okay, sorry.
You're going to jump right to the heart of the end of our program, okay. So we'll talk about that in just a moment. But we want to talk about triggers, and I want to remind people at home that you can get more information from NAMI Arkansas. There's a website, namiarkansas.org, and we have a phone number for you. It's on the bottom of the screen. I would make sure we'll mention that to you again throughout the program. So let's talk a little bit about triggers, because you were talking about the hallucinations and things of that nature. What sparks those hallucinations? Is there something going on in the brain that's causing this? What are the triggers for that? Who wants to tackle that?
Perhaps stress. I mean, the change from graduating high school, the stressors of life, moving to a new job, going to college, major life events could be a triggering event. So those are some things that happen on a normal spectrum, in someone's normal life process, but that may be a triggering event that caused them that triggers a psychotic episode.
So you're saying that a person could perhaps exist in what we refer to in kind of a normal set of circumstances, but something sudden could occur that could trigger a psychotic episode, if you will, and then lead to schizophrenia? Is that?
Well, what we know about schizophrenia, it's a very complex disorder. It's a very complex brain disorder, and there's still a lot that we don't know about exactly how it develops and what all of the risk factors are. But we do know that there's a genetic predisposition, and there is also often a stressor, like what Tony was talking about. Even sometimes certain substances can trigger a psychotic episode for schizophrenia, for someone who's vulnerable to schizophrenia because of their genetics, and launch them into a psychotic episode.
So is that something parents who have perhaps been battling with it should be on the alert for their children?
It's certainly a genetic risk, as Lisa said, and that means it's common in family members who have schizophrenia to have an offspring with a higher risk compared to the general population. We do know that there are a lot of twin studies that exist that show that correlation, and so we know that that genetic factor does play a part. Of course, stress plays a part, and as Lisa said, substance abuse, especially cannabis or marijuana, that itself predisposes someone to have that first psychotic break like we're talking about.
Okay.
But it is important for family members to know that if they have that in their history, just like anything else, a medical disorder you have in your history, it's important to educate your family and your children about that and the risk that family member might have, so they can recognize some of the signs and symptoms and intervene early, which is why we're all here, is to kind of shorten that episode where they're not treated.
Is it underdiagnosed, do you think?
Well, that's a complicated question. I think it's the diagnosis is not quick enough, and so people might delay seeking treatment for various reasons. For one reason, commonly people with schizophrenia don't have insight into their illness. That is, they don't think they have an illness, so that's part of schizophrenia sometimes, which makes it very difficult sometimes to engage somebody in care, to get a diagnosis, for them to tell you all the things that are going on in their mind, and even to keep them engaged in treatment. So that's one element that makes it very hard to get someone into diagnosis and to get them treated. Not everybody has that, but many people do. So it's really not underdiagnosed per se, other than people staying away from treatment. And different races and ethnicities sometimes have different diagnosis rates because of the way that they're diagnosed, not because they actually have different rates.
And of course, some of the symptoms like paranoia does create barriers in accessing treatment.
Right.
I do want to mention something about diagnosis. It is really challenging to diagnose psychosis or schizophrenia in young adults, especially teenagers. It does pose, this is a unique population that poses a lot of other complexities, and you do have to rule out other mental health disorders like depression or anxiety or substance abuse. And we're talking about early treatment, and that's really necessary. I mean, right now the treatment is, from the onset of symptoms to any kind of treatment is usually more than a year, maybe 2 years. And we do want to cut down that time. On the other hand, we do have to be careful of overdiagnosing young adults and teenagers, because the medications that we use for treating schizophrenia are pretty serious medications, and they have a lot of side effects. So we don't want to subject someone to these side effects of medications if they do not have schizophrenia.
And speaking of medication, is that something that if a patient is prescribed, it's something that they'll have to do for the rest of their lives to manage their care?
Most often than not, yes, because this is a chronic mental health illness. We do not have a cure for schizophrenia, and the best we can do is help control the symptoms. Now, saying that, there is hope for a lot of this population, and About half the people with schizophrenia, they go on to manage the symptoms pretty well, and they are functional in society, and they have a job. Of course, the goal for any persons with schizophrenia is to help improve the quality of life.
Mm-hmm. And part of the problem, as we were discussing off of the program, off air, is that there's a lot of stigma associated with it. Perhaps for the person who is battling it, because they may be in denial that they have a mental health issue, and then even for their families. What have you observed?
I think that is that's accurate. I think that there's a stigma around mental illness itself. And so people don't want to call it a mental illness. I think one of the things that we have to do as providers is meet people where they are. I had someone say to me the other day, I don't think I have a mental illness. And I said, okay. And we were talking about depression, and so we kind of had to call it what he wanted to call it in order to engage him. And so I think that is correct, that there is that stigma related to mental illness and psychosis itself.
I think that's a very good point. If you think of someone that is reluctant to get into treatment for depression, you compound that by having paranoia or suspicion that goes along with the symptoms of psychosis. Mm-hmm. So if someone is experiencing those symptoms of psychosis, they're suspicious and fearful already, you can just imagine how reluctant they are to get into treatment. Mm-hmm. I mean, as a whole, I think most people are reluctant to talk about mental illness. So this is even more difficult for them, and they're even more difficult to engage.
Mm-hmm. That's why these kinds of programs are so important.
Yes, I agree.
To help.
And one of the things that we kind of hope to do is to give hope to families and people who are experiencing schizophrenia. One of the things that we know that if we provide interventions, comprehensive, intensive interventions to people with schizophrenia, for example, supported employment, if we are able to provide those interventions, that we know that the baseline rate of employment goes way up. Mm-hmm. So even for people who still have symptoms. So the baseline rate of employment for schizophrenia is about 15%, but we can get that up into 60 and 70% if we do an intensive intervention. Still not everybody is working successfully, mm-hmm. But there certainly is hope that most people can go back to their normal role functioning.
That's great to hear. What's Arkansas doing in terms of kind of groundbreaking approaches, since we know that this is one of the challenges nationally in terms of access to care and treatment and prevention? I think you would be best to address that for us.
Okay, well, this is actually really an important time in the state of Arkansas, because our community mental health centers have committed to or beginning to embark on using a team-based approach. Mm-hmm. And that team-based approach encompasses the medication, the case management, family psychoeducation, and some individual therapies. And so we're really excited about moving forward with that work, and looking forward to helping the citizens of Arkansas.
So what's the first step in terms of that work?
Well, the first step is awareness, creating that awareness, mm-hmm. Allowing Arkansans to become aware that our community mental health centers are providing services, how to get there. You've provided the contact number through NAMI, so that's kind of our first step.
And that's important to note for folks at home who are watching, is that we have mental health centers in all corners of the state, and they provide much of the same services, I'm sure.
Yes. Okay. Then the two things that the mental health centers are trying to tackle right now as part of this comprehensive team-based approach for young adults with schizophrenia and psychosis. One of them is a very specific algorithm for medications that are targeting low-dose medications, and Dr. Kumar can talk a little bit more about that, and with a low-profile side effect. They're very complicated side effects, unpleasant side effects with some of the medication. So if we can reduce that and help that young adult stay on the medication, we can reduce the disability. So part of the intervention has a very clear algorithm for helping to make sure that they get started on the right medication from the beginning. and quickly. The other thing that we're working on is CBT for psychosis, which is a cognitive behavioral intervention that is designed specifically for people with schizophrenia to help with some of the things that Dr. Irwin was talking about, helping with relaxation and problem solving and those kinds of things.
Well, let's talk medication very quickly, and then, because this time goes by so fast when we're delving into the meat of the subject. Dr. Kumar, talk a little bit about the medication.
Right. So medications broadly fall into two categories. There are the typical antipsychotics, and then there are the atypical antipsychotics. And both of these are very effective. It's just they have a different side effect profile usually. Again, as I said earlier, a lot of these medications have very serious side effects that could range from a metabolic syndrome, which includes symptoms like increased risk of having diabetes or high cholesterol, which also increases your risk of having a heart attack or stroke in the future. Some of the other medications have other side effects, including movement problems, which we call dystonia or akathisia, the clinical terms, which essentially means you have problems with movements in your body and your muscles. And so we have to be careful about using those kind of medications. There are a lot of newer medications that are coming out now, which have slightly less of those side effects. And so, again, based on someone's insurance, some of these medications are approved versus not, and so a clinician has to make those decisions based on individual patient preferences, what they can afford, and of course, we want to expose someone, especially with a first onset psychosis or a first break psychosis, to a medication that they don't get scared about, using because of their side effects. The other thing we know about medications is, most of the times people discontinue medications because they're having side effects, and so that's another important thing to remember is we want to minimize these side effects for the simple reason that if persons with schizophrenia do not or stop taking the medications, they can go on to have relapses and go on to have more symptoms in the future.
So how do you make sure they take their medicines, their medication rather?
That's a tough job. A lot of times the rapport, the relationship that you build with someone that you're seeing helps a lot. And once they start to trust you, that makes it easier to convince them that they need to take the medication.
Okay. And one of the reasons this new approach, go ahead.
Well, I was just going to say that regarding the issue, that it's a very important issue to bring up about medication adherence. In Arkansas, we don't really have a mechanism of being paid for or using funds to provide a service that we call case management, where we go into the person's home and assist them with taking the medication, understanding the importance of it, and just helping them to monitor that. And Medicaid does pay for paraprofessionals to go into the home and help the person with certain things, but not specifically with that. And other things that insurance doesn't pay for in Arkansas are we talked about the need to help them with their educational pursuits and employment opportunities, vocational efforts, and we don't have any way to reimburse providers for those kinds of things they're not directly targeting the symptoms of schizophrenia, but that's how you help the person to really get on a track to recover from this debilitating illness. And we just need better ways to pay for those kinds of services.
So it sounds like what you're suggesting too is that we just need kind of not good, but great partnerships between community and the medical and general business community and even families to help ensure that patients can have successful outcomes.
That's right.
I think that's the key, is involving the family. If we're going to provide these support services, case management, involving the family and getting the family involved in helping that client or that patient along is very important. We find that the more family involvement we have, the more likely they are to engage in treatment. And stay on their medication. Yes.
Okay. Well, we're almost out of time, but I want you to give me kind of a quick 1, 2, 3, 1, 2, 3, about what to look for and what to do if you feel your child is experiencing this, or somebody, another loved one who may be having a tough time.
Well, you could probably, especially in a teenager or young adult, look for sudden changes in behaviors. That's one of the most common symptoms. Their grades dropping in school, that's another one. And of course, if you guys can talk about that more, but some of those are common symptoms.
Isolating from others, social withdrawal. or even odd behaviors, saying odd things, irrational things. But those are the more obvious things. But seeing a child that's pulling back from usual friends, staying in the room, I think you mentioned that, staying in the bedroom a lot. So if you're seeing those things, something is going on. Reach out and ask for help. And I would say call either NAMI, the number that we listed here, or your local community mental health center.
And how do you get that information? Through NAMI?
Through NAMI is
Through
probably
NAMI.
the easiest way to communicate that tonight is just
one-stop shopping under that umbrella. Very quickly, because I promised I'd get back to you with this. We don't want to leave people without a sense of hope tonight. And so you're on.
Well, thank you. I'm excited about what we're doing here in Arkansas with this, and like Fritzy said, that we've devoted some funds to make a kind of a renewed effort to help with this, and there is reason for hope. 50% of the people with this illness end up in some kind of employment. More than 75% of the people with this illness have a remission of symptoms, but the harder part is getting them back on track and functioning in wider areas of their life, and that's what we want to see a greater success with.
And that's what we're going to continue to work toward, thanks to you wonderful people in our community. Thank you for the work that you do, and thank you for adding your voice to this very important and timely discussion. And thank you at home for watching. We certainly hope you got some information that will be beneficial to you and your family to lead healthier lives.
Healing Minds, Changing Attitudes is underwritten by the Arkansas Mental Health Research and Training Institute.